Sorry about that, and I want to welcome everyone to Care Connection, the free live webinar, which is the second Thursday of each month. Today we have a very special guest speaker. His name is Dr. Ed Zammarini. He's a medical director at Roberts Memory Center in Sun City, Arizona. And today's topic is going to be of a memory concern visit with a specialist. Before we begin, I want to let everyone know for the duration of this program, we're going to be in listen-only mode. So what that means is at the end of the presentation, when Dr. Zammarini is done, we will be taking questions and comments on the right-hand side. You could type in your questions on the right-hand side in the box. In addition, we have included handouts, which are also on the right-hand side. And so now I want to begin our presentation. Dr. Zammarini, kindly tell us a little bit about yourself before we begin. Thank you.
Good afternoon, everyone. My name is Dr. Edward Zammarini. I'm the medical director of the Cleo Roberts Memory Center at Banner Sun Health Research Institute in Sun City, Arizona. I've been here for the past 2 years. Prior to that, I was a full professor of neurology at the University of Utah for 10 years, and I have about years of experience in Alzheimer's disease care, research, and so I'm with you this afternoon to tell you about making the most of a memory concern visit with a specialist. So many people have memory complaints. This is very common, particularly in the elderly, but even among young people, and I'll tell you a little bit about why. Primary care physicians can manage most memory concerns, and a specialist can help in more difficult cases or address more specific issues. Early detection of memory problems and early intervention is important to address reversible or causes, to improve quality of life, and to plan for the future. Preparing for the visit with the specialist will help you make the most out of that visit. So rather than spending a lot of Q&A time, what medications the patient is on, or what other medical conditions or past medical history is there, share all of this information in advance. It will allow you more time with the specialist to focus on your particular concerns and your questions. So in the beginning, memory concerns. A lot of people have memory complaints. Now, just because a person has a memory complaint or a memory concern does not necessarily mean that there is something abnormal going on. Memory complaints are very common in normal adults. All of us have experienced situations where in the middle of a conversation we're talking, oh yes, I met Mrs. Yes, I know, I can see her face in my mind. You know, she's my neighbor, she's been my neighbor for 10 years. And then you later remember, ah yes, I mean Mrs. Smith. So we all have these experiences of something being at the tip of our tongue, and it takes us a moment to get that. We also often forget where we put things, especially if we get distracted. Sometimes you know you told somebody something and you just don't remember that you did so, or you don't remember who you spoke to or what you told them. A common situation or a common example might be you're very proud of your grandchild who just graduated with honors, and so you tell everyone you meet, and you might tell 100 people, and so you might tell the same person more than once. And that's simply a reflection of your pride rather than that there's something actually wrong with your memory. We may also get distracted with the task we're doing and then forget where we were at or what we were doing. A common similar item would be, for example, if we're cooking, we get called to the door, and then somebody starts this deep conversation with us, we might forget that we have something on the stove. Other examples are getting a phone call or getting distracted by something happening that really requires our focus. Similar complaints are going into a room and then trying to figure out, well, what did I go into this room for? Then you backtrack and then, oh, yes, that's why I wanted to go to the living room. And so you go back there, and now you know why you went there. And people often also lose the thread of a conversation. And again, it depends on what distractions there are. So these are very common situations that occur with aging, but even in younger adults at times. And they don't really indicate any kind of pathology, just that we're distracted or that there are other things vying for our attention. Now, some things don't typically change with aging, while other things do decrease commonly with aging. Things that tend to be preserved include verbal IQ and vocabulary. So what we've learned throughout our lives, we tend to keep that kind of information solidly there. The store of information, again, through our experiences. And then our ability to understand language and situations. All of these tend to be preserved. Things that do decrease over time tend to be more time-dependent, such as how fast we are able to retrieve a particular memory. Just like the example I gave earlier about Mrs. Smith. Speed information. It might take us longer to solve a problem, even though we're still capable of solving it. Multitasking ability. Now, I have a few remarks to say about multitasking. There are different kinds of activities that people might consider multitasking. So an example might be walking and chewing gum. That's not exactly what most people mean by multitasking. And these are both background activities that we can perform, and neither requires a lot of our attention. However, when people typically think of multitasking, they're usually thinking about attending to two things at once. This is generally inaccurate. What we're doing when we think we're attending to two things at once is that we're actually shifting our attention from the one to the other. Younger people can do that a lot faster than older people. And no one can do that really well when they're driving and trying to text. So don't text and drive. Primary care physicians are usually able to manage most complaints related to memory. They're able to determine if a problem truly exists or if this is just within normal for age. They can also perform screening evaluations, and annual screening evaluations are encouraged by Medicare and by myself as well. Annual screening evaluations after age 65. So during the annual wellness visit, it's a good idea for the primary care physician to do a very brief screen for memory. The primary care physician can also look for clues during the interview, and I'll a little bit on that in the following slides. They can evaluate for reversible causes, for example, vitamin deficiency or thyroid problems, and they can request further workup. So if they have a suspicion that there's a problem, they might ask the patient to come back for a more dedicated visit to assess memory. Now, the primary care physician is usually familiar with the patient and can note changes in memory or thinking or behavior as they follow the patient visit after visit, year after year. They would be in a better position than others to assess, well, this patient has a 21 years of education. They used to be able to answer my questions very promptly, and now they're so because they know the patient, because they're familiar with them, they can get a sense of, is there a meaningful change, and is this change more than I would expect with age? The primary care physician usually has historical laboratory data on the patient, and so if they start to notice, for example, some changes in thinking or memory, and then that these changes might be coincident with laboratory changes, like changes in thyroid function or changes in electrolytes or changes in blood pressure. So they can have a better idea of what's going on with the patient. They're usually also familiar with the medications the patient is taking and can get an update in every visit in case another prescribed something. To give you an example, one time an 80-plus-year-old woman told me, my memory is declining. Ever since I broke my hip, I've had this pain, and I went to my orthopedist, so they put me on this medication, and ever since they put me on this medication, my memory isn't as good. And in fact, the orthopedist had placed her on a medication that is good for pain, but not good for memory. And so just switching that medication out was very helpful for this patient. The primary care physician is usually familiar with other medical conditions that the patient has. So for example, if a patient has renal failure and it gets worse, that can result in a failure. So these are all different examples in which the primary care physician, who is more familiar with the patient, can detect differences in cognition, but can also tell if these differences in cognition are because of a primary brain problem, or is this secondary to medications or medical conditions. Now, some other hints that might allow a primary care physician memory problem, whether the patient comes in or not, is if the patient is a poor historian. They're not able to answer questions directly, they're not able to provide timelines, they're not able to provide details. If the patient appears to avoid direct questions by changing the subject, a common example would be if the doctor asks, well, what's the date today? And the patient answers, oh, it's a beautiful day outside, it's quite sunny. Well, the answer may be correct that it's a beautiful day and it's sunny, but it does not address the question. And the patient may not be able to answer the question if prodded again to be specific about the date. So that would be a strong hint. Sometimes patients will have vague responses to questions, and they can't be very specific. Am I on this medication or that one? Am I taking this dose of medication or not? When did this problem start? A year ago? A year and a half ago? They're vague in their responses. And sometimes the patient cannot follow directions. So the doctor might say, well, tell me which finger I'm moving, as they're checking the peripheral vision of the patient. And the patient might not be able to follow that direction. One of the common telltale signs is if the patient is there with a companion, and as the doctor asks the patient questions, the patient keeps looking at the companion for answers. That's a big tell. If the patient relies on others for transportation, although that has to be taken with a grain of salt, because there may be many reasons why they might rely on others for transportation. But if they also have many missed appointments, then maybe they're forgetting their appointments or they can't stay organized. Finally, if they're not compliant with taking their medications, it could be because they forget to take their medications or they're not organized enough about scheduling their medications. Now, when should you suggest to the primary care physician, or when should the primary care physician think of referring a patient to a specialist? There's a decline in memory or cognition without an obvious pathology. In other words, nothing has changed in the patient's physical health, nothing has changed about the patient's medication or living conditions, but yet their memory seems to be worse visit after visit. When the changes are mild and they're not completely obvious, but the patient or the companion state, well, there are really a number of examples of memory loss. And so the patient might have the earliest signs, and it could be very difficult for the primary care physician to figure out, well, is this a meaningful change, or what might be causing these mild changes? If a diagnosis is in doubt, the primary care physician might want to refer to a specialist. I'll give you one example. One time, a family brought their loved one to the specialty memory clinic and said, well, you know, he's been diagnosed with Alzheimer's disease but we've heard that Alzheimer's gets worse year after year, and he's been stable for 8 years. So that would have been a good case to refer to a specialist, because there's doubt about the diagnosis. The course of the supposed diagnosis of Alzheimer's is in doubt here because the course is inconsistent with the provided diagnosis. It turned out that that patient had had a traumatic brain injury that coincided with the onset of memory loss, and that was a much better explanation than Alzheimer's disease. Sometimes there are no obvious changes, at least not in the clinic or in the office or on testing, the brief testing that the primary care physician might make, but yet the family and or patient are still concerned. Sometimes they're concerned not because there is a current memory problem, but they're concerned because of other family members or other people close to them that are developing dementia. Those concerns need to be taken at face value, and the patient may need to be assessed in more detail, and this can be done in a specialist visit. If the patient is interested in participating in research, now this could be a patient that's already diagnosed with a dementia or that has not progressed yet to a diagnosis of dementia, where they might have something called mild cognitive impairment, that is memory loss, but not enough to be labeled as dementia, but yet it changed from baseline. Interestingly also, today, people who are over 55 who are cognitively normal, but who are concerned about memory loss, or possibly because of family history, might want to participate in what are called prevention trials, trials with medications to attempt to delay onset of Alzheimer's disease in people at risk. Now, most primary care physicians won't have access to those kinds of trials, but they can certainly refer the patients or the normal volunteers to specialty centers for participation in research. And finally, primary care physicians don't always have good access to memory specialist social work services, but yet specialty clinics could have access to these. And so that would be a good indication to refer to a specialist. Now, the specialist visit is often more than one visit. The initial visit will be to gather information and to review what tests have been done and to order any additional tests that may still be needed. Then a second visit would be a follow-up visit where all the data is reviewed, the history is checked again, more details are obtained, and then typically a diagnosis is made, and the specialist will recommend a plan of action. Sometimes during the second visit, the results of the tests are either ambiguous or indicate that more testing is indicated. And so occasionally there's an additional third visit before a diagnosis is made and the specialist recommends a plan of action. So if you do end up with a specialist visit, what should you do to prepare? How can you prepare? The less time you spend trying to remember information during the visit with the specialist, the more productive your time will be with the specialist. So how do you prepare? First, get the history or as many details of the history as you can already in your mind, or jot down some notes. Number one, what is the main concern, or what is the major question you have for the specialist? Sometimes people come in and they have a whole host of concerns, but it's difficult to address all the concerns. And so you have to look at what is your main concern or the biggest one, and be clear in your mind about what is the one overriding issue you want to have addressed. Other issues can be addressed either later or if there is additional time during this initial visit. But make sure that you address the main concern and try and focus on the main concern. That way, at least, you'll have some answers. The specialist will want to know, how did the symptoms start? It's much easier for the specialist to formulate a possible diagnosis or have a differential diagnosis, that is, consider several possibilities, if they know, if they have a historical timeline. For example, when did the symptoms start? How long ago? Did they start suddenly, or did they start slowly and get worse over time? What was the first symptom, or what were the first symptoms? Think of examples such as, well, the patient started repeating the same question and that was of concern, rather than just saying memory loss, because memory loss could be a lot of things, and memory loss isn't necessarily something to worry about if it is within the range of normal, as in the examples I gave you earlier. So giving an example of what were the first things that raised an alarm can be very helpful. Next, the timeline. How did the symptoms progress? Did they stay the same, as in the example of the person with traumatic brain injury that I gave you, or were they gradually worse? Or did the symptoms fluctuate? They get worse, they get better, they get worse, they get better. Because the course of the illness or the progression of symptoms is going to be according to causation. So if the symptoms keep getting better and worse, it could be an illness effect, like a medical illness. It could be a medication effect, or it could be a situational effect. And it's going to depend on how this progressed and what associated elements can be found related to that. For example, if a person becomes confused every time they have a urinary tract infection, and there is a timeline, a correspondence of timeline, well, then that makes sense. And it's not considered to be a dementia. It might be considered to be a delirium due to infection, for example. The caveat being that patients sometimes can have both conditions, dementia and delirium. So delirium is typically time limited, whereas when we talk about dementia, it's usually over a long period of time. The specialists will also want to know, are symptoms limited to memory, or do they include language skills, problems with recognizing things, either faces, places, items, or problems with judgment or solving problems, or changes in personality or mood. And depending on which symptoms started first, the causation may be different. What are the patient's functional abilities? That is, what can the patient no longer do that they used to be able to do? Examples of that: are they still able to perform all their household chores, or they're taking care of the yard, or taking care of problems around the house? Or have these skills? What hobbies and activities are preserved? Which ones are lost? This gives us an idea about whether the patient has reached a stage of dementia, or if they have not reached that level of severity. Also, they help us with having an idea of at what stage of dementia the patient might have. It's also useful to know what the patient is still good at, because many patients with dementia are still good at many things, and it's important to allow them the freedom and the respect to be able to do the things that they can still do. The specialists will want to know about the past medical and past surgical histories. What medical conditions does the patient have? For example, do they have a history of heart disease, coronary artery surgery, atrial fibrillation, heart failure, things of the sort? Are these problems still active, or have they been resolved? What surgeries did the patient have? When? For what? And what was the outcome? Do they have any allergies or any drug sensitivities or drug reactions? Not all drug sensitivities or reactions are allergies. Allergies are when there's an immune response. The specialists will want to know about family and social history. Are the parents still alive? How old are they? If they're deceased, at what age did they die, and from what? Do any siblings have similar symptoms of memory loss or problems with thinking? What's the patient's level of education? What was their main occupation? If they're retired, when did they retire and why? Sometimes, for example, people might say, oh, I've only had memory problems for the last 3 years. When did you retire? I retired 5 years ago. Why did you retire 5 years ago? Well, they had me doing new tasks, and I was having trouble with these new tasks. Well, that might suggest that the memory problems or thinking problems actually started 5 years earlier rather than 3 years earlier. Also, the doctor will want to know if the patient is still driving and if there are any concerns related to driving. What medications is the patient on? Some medications can affect memory. They might not be the principal cause of memory loss, but they may contribute to memory loss. So it's important to note current medications and dosages, why the patient is on the medication, and what's the outcome of started the medication. Did they have response or no response? Did they have side effects? What were the side effects? And the side effects, did they occur at a high dosage or a low dosage? What dosage did the side effects occur at? It's important to note that sometimes if a medication is used and there are side effects, you don't want to use that medication again. However, there are other times where a medication is used and the patient does not tolerate the higher dose but has a good response to a lower dose. In that case, we don't want to throw the baby with the bathwater, so to speak. We might want to use that beneficial medication at a low dose and keep it at a low dose. The specialist will perform an exam to look for any telltale signs of potential causes of cognitive impairment, and they may want to do some pen and paper evaluations. They'll want to order some blood tests if these have not already been done, such as blood count, that's how many red blood cells and white blood cells there are, a comprehensive metabolic panel that includes electrolytes, liver functions, and then check on vitamin B12 level and thyroid function. They may order other tests depending on the history and the exam. They will typically order neuroimaging. We like to order MRI scans because they provide more detail than CAT scans, but sometimes patients cannot get an MRI scan because they have metal in their body, and in that case, a CAT scan may be ordered. Occasionally, other imaging tests may be ordered. Typically, specialists will order a neuropsychological evaluation. This is a very detailed pen and paper testing that takes 3 to 4 hours. The patient is allowed time to rest in between or take breaks if they need them. Sometimes doctors might order an automated test, that is, have the patient sit in a room with a computer screen and with someone to help orient them to the tasks they need to do on the computer screen. Typically, the in-person neuropsychological evaluations provide more detail and tend to have better results. But if one wants to do more screening evaluations, these can be done with computer assessments. The specialist may want to order additional tests depending on their conclusions so far. So they may order a PET scan, cerebrospinal fluid. This is the fluid that the brain and the spinal cord bathe in. And to obtain the cerebrospinal fluid, one needs to have a procedure called a lumbar puncture, where the doctor goes in the sac, the cerebrospinal fluid, at the bottom of the spine, below where the spinal cord ends. The specialist may want to order EEG in select situations or other more esoteric tests, again, depending on the situation. Now, some of you may have heard about PET scans. Now, PET stands for positron emission tomography. And not for the kind of pets we might have at home or as you might see in some cartoons. So positron emission tomography scans come in different types. You can have a metabolic PET scan or a molecular PET scan. The metabolic PET scan is also known as FDG PET or fluorodeoxyglucose PET. What this kind of scan does is it measures glucose utilization, and glucose utilization is a surrogate for activity of communication between brain cells. And so by looking at the pattern of reduction of glucose utilization, the doctor can often tell, is this a pattern of Alzheimer's disease, frontotemporal degeneration, which is another cause of dementia, or some other. Molecular scans tell us about specific kinds of proteins or molecules in the brain. So recently, amyloid PET scans have been approved. Amyloid is a marker of Alzheimer's, but it doesn't tell us what the patient's cognitive status is. It just tells us if there is amyloid or not in the brain. It's up to the specialist to then determine the meaningfulness of this amyloid PET scan in a particular situation. So the amyloid PET scan only informs if there is the position of abnormal amyloid above or below a certain threshold. And if it is above a certain threshold, it means that the person has Alzheimer's disease pathology, but the person could have normal memory, could have mild cognitive impairment, or could have Alzheimer's disease dementia with a positive amyloid PET scan. So it's important to have a discussion with the specialist if you ever have an amyloid PET scan, what that scan means in your specific circumstance. The FDG PET scan inherently measures spread and severity of impaired function of nerve cells. And like I said earlier, it helps us know, according to the pattern, which disease we're likely dealing with. Cerebrospinal fluid analysis can help us know if abnormal levels of amyloid and tau, the two abnormal proteins associated with Alzheimer's disease. EEGs, or electroencephalography, is infrequently used, but can sometimes be helpful in letting us know if there is associated seizure activity or significant asymmetry or significant localization of pathology. Other tests that may be used include tests to look for inflammation or other chemical abnormalities. For example, abnormalities with copper metabolism, just as an example. But it's rare for us to order such tests. It depends on the history, the exam, and the family history. Genetic tests are not routinely ordered. About 0.5% of cases of Alzheimer's disease are due to deterministic genetic mutations. So that's a very small minority. We suspect genetic abnormalities in people who develop Alzheimer's at a young age, for instance, below age 50, when there are multiple generations of family members and multiple family members that are affected in the same family. These genetic tests can be ordered, but we don't always find the genes that we know of that cause familial dementia. But just be aware that there are select situations where genetic tests may be pertinent. In the vast majority of cases, we don't order these specific kinds of genetic tests. Now, a risk gene for Alzheimer's disease is called apolipoprotein E4, and many of you may have heard of it. In large groups of people, if you look at the percentage of apolipoprotein E4 in large groups of people, you'll find that there's an overrepresentation of this gene in people with Alzheimer's disease. However, for the individual, it's not particularly predictive. So a person could live to beyond age 90, have apolipoprotein E4, and never develop Alzheimer's disease. So we don't order this test. Now, for the diagnostic visit, after the specialist receives all the basic tests and additional tests, the specialist will be able to formulate a diagnosis and recommend a plan of action. Now, it's important to make a specific diagnosis and not just say dementia. It's a little bit like if a person develops a pneumonia, you know that they have a pneumonia, but you don't know what organism is causing the pneumonia. Or worse yet, if a person has a fever, you know they have a fever, so something is wrong, but you don't necessarily know what's causing the fever. And so you need to be specific about the cause in order to treat the underlying cause. Similarly, just stating that a person has dementia is somewhat informative, but not adequately informative. Dementia is a generic term indicating that there is loss of memory and other cognitive skills with an inability for the person to manage their own affairs. But if we say Alzheimer's disease or frontotemporal dementia or vascular dementia, we're being very specific about the cause of dementia. The treatment, the prognosis, the strategy of dealing with the disease, future planning, and genetic risk implications for other family members are different according to the specific diagnosis. So it's really important to be specific about the diagnosis. Now, management plan isn't just here, take a pill and go home. Management plan, when it comes to cognitive disorders or dementia, is very complex. Management plan is multifaceted. It includes counseling, certain medications, possibly consults for other services. For example, perhaps a consult to occupational therapy for a driving evaluation, or perhaps a consult to a psychiatrist to deal with the emotional consequences that may be part of the presentation. There are often community referrals, such as referral to the Alzheimer's Association or referral to social work for advice about planning for the future. One has to address activities, and I'll be talking about these in a little bit. I already mentioned driving evaluation, and everyone, frankly, everyone 50 and older should probably have advanced directives and post-mortem plans. What I mean by post-mortem plans, would they like to have an autopsy or not? Would they like to donate their body for research or not? Or what would they like to happen? And then it's important to consider medical research options. As I mentioned earlier, medical research has advanced now to where we not only have research studies for patients with Alzheimer's disease, but also in a pre-Alzheimer's condition called mild cognitive impairment, and in what's called preclinical Alzheimer's disease, that is for people at risk for developing Alzheimer's who are cognitively normal. Now, you won't know if you're at risk unless you get tested. And typically, such testing is not covered by insurance, but it would be part of research evaluations. Now, treatment options, I like to divide these into non-medicinal treatment options as well as medicinal. In the non-medicinal, we're talking about looking at the patient's behavior and modifying our response to the patient's behavior or our behavior in order to modify the patient's behavior. Looking at the patient's environment, their physical well-being, for example, are they in pain, and their social needs. Medicinal can be divided into two categories, those for cognition and those medications for behavioral problems. So non-medicinal management includes making an appropriate diagnosis, counseling the patient and their family, planning care, and connecting with community resources. Non-medicinal management has to take into account the patient's history, their habits, and maintaining the patient's dignity as a major goal, and focusing on the patient's quality of life. These alone can take a whole lecture by themselves. But just as an example of behavioral management, maintaining a routine is very helpful for the patient, preserving familiar surroundings, training the caregiver on how to speak to the patient and how to interact with the patient is very important. Optimizing the patient's capabilities rather than trying to do everything for them, and making sure that their general health is managed to the optimal level. In brief, anything that is good for the heart is going to be good for the brain. Now, I've listed on here a lot of sources of information about clinical trials and about trials recruiting for mild cognitive impairment, and a lot of these resources, over here, will also include information about trials for Alzheimer's disease, other dementias like diffuse Lewy body disease, and for pre-dementia conditions. So you can access these there in the handouts you will receive. And so I'd like to acknowledge the Sun Cities where we are, and all the people and all the organizations that have contributed to our ability to this kind of information and the kind of research that helps advance our knowledge, and the National Institute of Aging, the Banner Alzheimer's Foundation, the Sun Health Foundation, and of I would like to thank the Alzheimer's Foundation of America for hosting this program, and I'll be happy to take questions at this time.
Thank you, Dr. Zammarini. That was wonderful. I certainly learned some new information today. So I want to let everyone know again that please type in your questions on the right-hand side. I will read them, and Dr. Zammarini will answer. I just want to remind you, Dr. Zammarini is here to answer general questions, not specific health questions based on specific individuals. Thank you. I have a question from Mary. Mary wants to know, as a doctor, how could you help a client become comfortable in the exam room in terms of getting a diagnostic process?
That's a very good question. How to help the patient feel more during the visit. I think there are many factors, and many factors are important, not any one overriding all others. So I would say the approach of the physician to start with when they first come into the room, I think it's important for the physician to feel comfortable in their own skin, to smile to the patient, and to greet the patient first rather than greeting other family members first. The patient recognize that the physician is focused on them. Also, the smile and the warm greeting helps put them at ease. Next, typically when I see a patient in my clinic, I will very clearly look at the patient, make eye contact with them, and let them know, I'm going to chat with you first, and then I will look over to your family members and chat with them as well. So that is a nice indirect way of letting family members know not to interrupt, to allow the patient to feel that they are valued, they are respected, their dignity is being respected, and that they're being given a chance to voice their concerns. Of course, there are many times where the patient is unable to provide a history, unable to voice their concerns, but it still is important to let them know that they are respected by actions, not just by words. The other thing, it's important to reassure the patient rather than challenge them, well, you do have memory problems, don't you? Is to simply ask them, what is your concern? Why are you here? And if they say, well, my family wanted me to come here, well, why do you think you come here? Or why did you agree to come? So there are many ways that the physician can, in a nice tone of voice, with a reassuring tone and a reassuring smile and reassuring eye contact, demonstrate their respect for the patient. Sometimes the patient will say, well, I'm crazy. And clearly they're not crazy. They may have a memory problem, they may have dementia, but that does not mean that they're crazy. And it's important to reassure them that way. Well, it looks like you have a disease that's giving you some difficulties, and let's find out more about that so that we can look at our treatment options. That's being honest with the patient, but also demonstrating a lot of respect to the patient. I hope that answered your question.
It did. Thank you. I have another question from Susan. Is it important to determine the stage of Alzheimer's?
Well, in my opinion, for me personally, I don't think it's as important for me personally to determine the stage, but again, with some caveats. Number one, it's often important for families, and since it's my job to be respectful and attentive to the family's concerns, in that regard, yes, I would want to let them know what the stage is if they're interested. One reason I hesitate to stage patients is because a patient could have mild difficulty in one area, moderate difficulty in another, and more severe difficulty in a third. So do I label them as mild, moderate, or severe? Well, I prefer to be specific in what areas does the patient have difficulties and how are we going to address those difficulties. In general, however, for most people, they either want to know which one of the 7 stages is the patient at, or what I would prefer to say, are they in a mild, moderate, or severe stage of dementia? Because it kind of helps them frame where things are at and what they might expect. So on the one hand, yes, it's useful information. On the other hand, we shouldn't be too stuck with what stage of dementia are they in, but rather focus on what are their capabilities. Let's try to maximize those. What areas do they need help? Let's look at how we can address those those areas.
Thank you. I have another question. If my father is living with dementia and he was recently diagnosed, should the primary doctor be the person we see, or should the neurologist be the primary doctor?
Typically, if the loved one has typical symptoms of Alzheimer's, the basic workup has been done, and it looks like Alzheimer's in all respects, most primary care physicians are able to handle that. Now, if there are specific special circumstances or specific special questions or specific concerns that the primary care physician or family have, then it's reasonable to refer to a specialist. But just because there's a diagnosis of dementia and the cause of the dementia has been identified as, say, Alzheimer's or whichever other cause, doesn't mean that a specialist has to be called in and that the patient has to be followed by a specialist. Sometimes families will want to feel more confident about the diagnosis, but then once a diagnosis is made and a plan of action is made, the patient is referred back to the primary care physician to handle the patient from that point onwards. So you can have different levels. I would say if the primary care physician is confident with the diagnosis and the management plan, and the family are comfortable with that, then there is no need for a specialist. If there are doubts on either end, it's reasonable to ask for a specialist referral.
Thank you, doctor. That was great. And we are in the process of ending today's presentation. I just want to remind everyone that next month, September 14th, from 1 to 2 p.m. Eastern Time, we will be having our webinar. Our guest speaker will be Marcy Hall, author and biologist out of Portland, Oregon, and that topic is going to be misunderstanding pain in dementia care. I want to thank Dr. Ed Zammarini for today's presentation. I certainly learned some new things today. I thank everyone for joining and the wonderful questions, and I hope to have everyone back next month, again, September 14th from 1 to 2 p.m. Eastern Time. I hope everyone has a wonderful rest of the afternoon, and thank you for Care Connection, and we welcome you to call our helpline if there's further questions or concerns here at AFA, and we're available Monday through Friday, 9 a.m. to 9 p.m. Eastern Time, 7 a.m. to 1 p.m. at 866-232-3224. And I want to just remind everyone on the right-hand side to take along. Again, have a great rest of the afternoon. And Dr. Zammarini, thank you once again for your wonderful presentation.
Well, thank you, and thank AFA for hosting. Thank you all for attending. Good afternoon.
All right. Have a good day. Bye-bye.